all, good morning. It is really thrilling to be here, and I mean thrilling. I'm sure many of you feel the energy that is in the air if you arrived yesterday or this morning. And this, just by show of hands, for how many of you is this the first meeting that you were attending in person since COVID? It's almost everybody, so except for the brave few who've been able. Yeah, it's almost everybody. I mean, this is really a wonderful moment. A wonderful moment for us, a wonderful moment for the country, and dare I say it, a wonderful moment for science that we've gotten to this time where we're able to meet in person. So thank you for what you've done over the last couple of years. And I mean this, you're all, I think, nearly all of you are emergency physicians. And you've really been on the front. I've been watching all this from the front page of the New York Times and reading about it and commiserating with friends. You guys did an incredible job. And the research is one thing, but the patient care is really what this is all about. And I just want to say thank you as someone, as I said, who doesn't practice clinical emergency medicine anymore, did for 2 decades, but not anymore. To have watched this go on and to know what it was that you were all doing with, as we know, sometimes under-resourced and overextended emergency departments, it's really amazing, and again, I thank you for it. Okay, so we are meeting in person, which means let's take advantage of it. Ask me questions if something is not clear, you want clarified, just shout it out. That's why we got in the room together, right? So I'm going to talk to you this morning about grant mechanics. And it's important to note that when we talk about grant mechanics, when we talk about mechanics in general, we're talking about the machinery or working parts of something. And mechanics is also a branch of applied mathematics dealing with motion and forces that produce opposing motion. And that's really kind of what this is all about, right? There's the motion of your idea and the motion of getting it into writing and the motion of getting it reviewed. And then, there's a pushback. There's an opposing force. Did you think about that? You should have worded this differently. Have you thought about this problem? So it's very much an ebb and flow, a push and shove process. And it's a bit like swimming through honey, something I've not done. But I imagine, at first it's like, oh, this is all golden and sweet, but pretty soon it gets very tough. So getting a grant funded by any agency, an agency here we mean a foundation, the government, your hospital, your state health board, whatever it is, it requires stamina. It requires you to say, I believe in this, and I'm going to see it through. And that stamina is a very important part of what we're going to be doing. You have to keep going. I'll bring some examples from my own research career. You have some very experienced mentors and guides in the room who will, I'm sure, share their own stories with you. So don't think that just because you thought something was a good idea, and it was a good idea, how could you not fund this? What are you talking about? This is brilliant. We all think our grants are brilliant. We all think our papers are fantastic. And then when we get that no, it's quite deflating. So you have to have a little bit of personal stamina. You have to eat your Wheaties or your spinach in the morning and make sure that you are really ready for this. So this is basically the sketch of what I'm going to talk about for the next 40, 45 minutes or so. And it's kind of complicated and messy, and I'm going to take you through each of these stages from idea, where you go, how you figure out budgets and stuff, until you get to the submit stage. And it can sometimes seem a little overwhelming, but I want you to know that the NIH is really here to help you, and the Office of Emergency Care Research is here to help you. Some of you in the room will not need the Office of Emergency Care Research. You have an idea, it goes to and I'm going to explain exactly how NIH works in 30 seconds, but some of you don't need me. You know what you're doing, you have a good contact, maybe you have a good mentor. You've already, how many of the people in the room have already submitted an NIH grant? So a few of you. So you have a contact. Great. You don't need me. You don't have to. But for those of you who are starting or who are not sure, or who very commonly I get this question, I have this idea or I have this project, I'm not sure who to start talking to. Talk to me and I will help find the person that you can then start talking to. Okay. How do we begin our research? Now, for some of you, you know exactly what your research projects are about or your mentored awards are about. But for others who are saying, I want to do research, but I'm not really sure. I don't have this project yet. Where does it come from? And I'm going to talk to you about what I did for what happened with me. I was working in Washington. This would have been, gosh, a long time ago. 2004, maybe? It's a long time ago. And I was in the ER one day, and I was discharging a patient who had a kidney stone. And there was a urologist in the ER. I don't know what he was doing there. And he said basically, don't forget to put him on tamsulosin. Now, I wasn't his patient, so mind your own business, number one. Number two, what are you talking about? I've never heard of this. And remember, I come from Boston. Boston. If that's not the way medicine is practiced in Boston, right? It's not correct. So what is this guy talking about in 2004? Give this guy tamsulosin. How many of you give tamsulosin for patients with kidney stones when they leave the ED by show of hands? Some of you, some. Only if the urologists, yeah, they should mind their own business, shouldn't they? All right. Well, in any event, so he goes, give him tamsulosin. Now, I had only arrived in Washington fairly recently. I'd come from Boston via Israel and come to Washington. So I thought, well, you know what, that's kind of interesting, but maybe it's like a Washington thing. There are lots of weird Washington things, mostly in politics, and they're very weird. But maybe it's a Washington, right? Because we know there's a regional practice. For those of you who have moved from a training institution, perhaps across the country or to a different state, there are different ways of doing things, and I think that's terrific. I think it's great when programs actually hire people from outside their residency because, right, we get cross-pollination and we figure out, and it's not only one way of doing things. Anyway, so why is the urologist tamsulosin? Then I thought, okay, so it's a regional thing. It's a Washington thing. So at my Lex faculty meeting at GW, I said, oh, by the way, does anybody prescribe tamsulosin for patients with kidney stones? And they all looked at me like, what is this guy talking about? So you ask your colleagues, when you come across something that is puzzling or that you think might be done a different way, you can, your colleagues are a really good resource. So I had this idea, why is the urologist prescribing tamsulosin? Does anyone else do this? And of course, the next thing you want to do is go to the literature and see what is out there, right? Because the fact that you are not doing this in your own institution, or you're doing it this way in your institution, of course, is only the way that you're doing it. And the literature review, PubMed, it's so easy now, right? We carry the whole world's information in our top pockets, right? I mean, it's incredible. When I started medical school, we had the Index Medicus on the shelf. That is how old I am. And then we had these little, you would type a letter to the author asking for a reprint, and they would eventually send it to you in the, I mean, yes, it makes me sound like I'm in the 1500s, but that's actually what was going on in 1980s. All right, and then you formulate the clinical or basic research question. So I've asked around. It seems like there's something unusual here, or I think there may be a better way of doing things, or why do we do things this way? Formulate the question. And my question then was, what is the effect of tamsulosin and steroids on patients who've had renal colic? And the steroids were because of those people who give tamsulosin, even if it's only because the urologist, as Sarah said, but how many of you give steroids as well to reduce the inflammation in the ureter? Makes sense, actually. Ureter's all angry and annoyed at that horrible 4 millimeter stone grating its way through it, gives some steroids, calm the inflammation down. Anyway, back in the day, that was the idea, tamsulosin and steroids. So I formulated this question, the effect of tamsulosin and steroids for renal colic. Okay, so that's how I got there. It really began by this bozo called Steve Jackman, who's, I think, still at the University of Pittsburgh. I think he's at Pittsburgh. Great guy, by the way, not a bozo at all. Turned out when I did my literature review that he was the one who was on top of this game, and I was not current, because the Italians in the 1990s had been doing this. The Italians had been giving tamsulosin and steroids to patients with kidney stones. Now, when you start reading their papers, you realize they do things a little differently. So they would admit every single patient who had a kidney stone. Well, we don't really do that. And they would do serial KUBs every day until the stone passed. Well, okay, well, that's a lot of exposure. And anyway, so you can see, it's a different medical system. But anyway, the literature was about 10, 15 years old at the time. The urologist, far from being the bozo, was the one who was on top of it. I was behind in my game. My colleagues didn't know anything about it. This is a really interesting question to pursue. Okay. There are other places you can look at. One is Nih Reporter. The Nih Reporter is a website that gives you information about every funded NIH grant, tens of thousands of grants a year, every funded grant. So you could type into your web reporter, you could type in, kidney stones or renal colic, tamsulosin, and you will get a hit, if there is one, on every study that has been funded. So it may be that you have a brilliant question, but you know what? Many of our brilliant questions are so brilliant that other people have asked them too, and are asking them, and have perhaps asked this a year or two ahead of you and have gotten funding. So have a look at Nih Reporter. It's also interesting, by the way, to look at Nih Reporter to see, things that are not funded. You might have a great idea and find out that nobody's funding it, and that might tell you not to go ahead. And the classic example of that, of course, is gun control. Right? For years, decades, NIH was under a moratorium, basically not to fund any research on gun violence. What a terrible thing that was. It's changed, but there's an example why I want to look into this. I treat gunshot victims, and I want to do something, and I have this clinical question. Well, turns out NIH wasn't funding that money, wasn't funding that area for a good reason. Actually, for a terrible reason, but there was a reason. All right, so you can do that. And then the other thing is the Office of Emergency Care Research website, where I have examples of grants that you can look at. I have lists of funding by specialty and by specialty, I think, and by institute. So you can look and see, okay, show me all the neurologists who got funding in a certain year and things like that. So you could look at that too. The website has actually recently been upgraded, so it may not have all, the dust may not have all settled, but it should be there. Okay, but these are really important things. PubMed, Nih Reporter, to get you thinking about where I can go next. Now, then you get to the next one. So you have an idea, you've done your research, you've checked in with your colleagues. Where do I go next? Where can I get my funding from? And the first question I think everybody needs to ask themselves is, well, what do I need the money for? Why do I need money in order to do this project? Some of them obviously I need money. For example, when I did my study on tamsulosin, I need money because I need to make placebo. And to make dummy placebo pills is actually quite an expensive proposition. So there's just one thing I need money. But if you have a project, the first question I really want you to ask is, what do I need the money for? Right? And that will help guide you. You may not need money. You may not need anything other than sweat equity. And don't underestimate the importance of sweat equity. Don't underestimate the importance of putting in the hours that are unpaid at the beginning so that you can get your project off the ground. I don't think any of us went into medicine to become very wealthy. We're all going to do just fine, but we do this because we have something other than a need to make money. And we do have to put some equity in terms of sweat equity. So So it could be that your project doesn't need money, in which case go ahead and just off you go, do it, right? Start it, get a pilot study going or whatever it is. But most of the work, certainly clinical trials, most of the work will at some time or other need money, if only to pay for other people's time, your statistician, or maybe you don't need a statistician, but most of us will end up needing money. And then you've got at least two other routes to go. One is obviously through non-NIH, private pharma foundations, the American Medical Association, the various disease-focused patient organizations, right? Breast cancer and Autism Speaks. And I mean, there are many, many diseases out there that have large patient-led organizations and have some pretty deep pockets. And those should be things that you think about. Now, unfortunately, for many of the common diseases that we treat in the ED, there is no patient lobbying group. There's no the National Association of Patients Who've Had Pneumonia. It doesn't exist. So if you're going to do a study on pneumonia, that's probably going to be quite challenging. But for many, there are, and I think you should be at least considering these. The money is sometimes easier to get, and it's usually always quicker to get. It may be less prestigious, we'll come to that, but if you need money and this is something that you can do, then think about that. Your hospital might have money, state funds probably not, but maybe, and as I said, foundations are really very well endowed, and with the stock market being as hot as it was until recently, these foundations often have more money than they know what to do with. Doesn't mean they're going to give it away, but you should think about that. Is there a patient advocacy organization that I can approach or can get behind my study and support me? And then of course is the NIH, and that's what I'm going to focus on as we go forward. The NIH, let's be honest, is prestigious, right? You say I'm an R01 funded, or I'm a K awardee, or whatever it is. It's prestigious. Your departments like it, your medical schools like it, and so it helps with academic promotion. It helps a lot. Some places you can't get much, there are certain places you won't be able to get to without an NIH grant. So it's prestigious, it helps with academic promotion. The indirects are huge. So the indirect costs are the costs that if you apply to NIH and say it's going to cost me $1 million to do this thing, your institution will get anywhere from $1.5 million to $1.8 million. Some indirects, some places have indirects as high as 84%. So for every dollar that you ask for, the government will give your institute $1.84. Most of them hover around the 50% mark. For those of you who applied, who said you've already applied for an NIH grant, do you know what your institutional indirects are? 62%, okay. So for 54, yeah. These things, so why is 160 and 150 and these are regional, basically the university has to say, this is how much it costs to keep the lights on where we live. This is how much rent costs. This is how much we have to pay, our support staff. So your institution, which was what? NYU. So yeah, the New York area, Boston, of course. I think, anyone from the Harvard system here? How much of the indirects are Harvard? Oh, I thought it was higher. I thought it was 80. Okay. But anyway, these are negotiated, and the government, the NIH says, yeah, this is what we're going to pay. So for every dollar you bring in, the indirects are at least 50% higher. Do you see that money? Do you see that money? You don't see a penny of it. It is eaten up by the research infrastructure / dean of the medical school / department chair. Nobody knows where it goes. I never figured out where it goes. But it goes somewhere, and it's a lot of money. And I still don't believe people when they say we lose money on research. Chairs say this. I've never really been able to drill down and figure out how exactly they're losing money on research. I'm sure it's something that I don't understand. But my grant was a $4 million grant when I finally got it from NIH. And at 52%, that means that I brought in about another $2 million to the George Washington University Medical School. That is a lot of money. So you should be nice to me. And they were kind of nice to me for a little bit. But yeah, so the indirects are huge. The indirects are huge, and you'll get a lot of respect for having done that, and you should. You should. Okay, so that's the good reasons to get an NIH grant, right? It's prestigious, helps me with promotion. I can get my grant done because they'll give me the money, and I get these massive indirects. And by the way, foundational indirects are either much lower, maybe I'll give you 10%, or they're non-existent. They'll say, we don't give indirects. This is the grant. This is what you're going to get. You told us you need $150,000 to do your grant. Here it is. No indirects. And then your chair will say, yeah, well, you know, I need something. So that's where the negotiations begin. But okay, the problem with NIH is it's a slow process. If everything lines up really well and you get a great score, it's going to probably take at least 18 months from the time you submit till the time you can start your project. And that's if everything lines up really well and you don't have to resubmit. It's a long time, a year and a half, right? It's a long time. And the success rate is low, about 15% or so for R01s. R01s are the most common NIH grant, and it means it's an investigator-initiated grant, meaning I come along to NIH, I say I have a great idea, please give me the money. That's an R01. And that's, you know, when we talk about an R01 funded researcher, that's what we mean, that she has this money from NIH. She must be very clever because the NIH have said, here's your money, report back with your results in 5 years or whatever it is. So that's an R01 grant. And there are probably more people who get non-R01 grants now than R01s, but that's what it is. Okay, so it takes a long time and the success rate is low. It is, 15%, that's low. Now, you have to think about the success rate in terms of first-timers, people who just submit their grant and then wait, versus people who are resubmitting a grant based on the feedback that they got. And the success rate of that second group is higher. So it's a bit more complicated than that. But overall, your initial chance of getting funded is 85% of the grants are not going to get funded. So that's funding. Now, the NIH has a definition of a clinical trial, and this is important because most of us in the room, or many of us in the room, will want to do a clinical trial. We won't be asking for bench research. We won't be asking to work on microscopes or on mice, although that's absolutely fine if you want to. My office focuses on clinical research for a number of reasons, not least of which is the reason that I think basic research at NIH is doing just fine, thank you very much. Most of the NIH grants are basic research. So when it comes to a clinical trial, the NIH says, well, a definition of a clinical trial is one in which we're doing it on people, so not mice, and we're prospectively assigning them to an intervention, and then we're evaluating that intervention, very straightforward. And this is important because you need to figure out if what you're going to do is a clinical trial or not. And the reason that you need to do this is some grants say, at NIH say you can't do clinical trials using this mechanism, right? So you do need to think about that. So is this a clinical trial? Am I using people? Am I prospectively assigning them to an intervention? Is the study going to evaluate the effect? Is it being evaluated for a health-related biomedical or behavioral outcome? And if you answer yes to these questions, you are doing a clinical trial. Congratulations. So that's something we need to think about. It's going to be pretty obvious to most of us that we're doing a clinical trial. And have to keep it in our minds, as I say, because some mechanisms don't support a clinical trial. So what is this thing called the NIH? Yes?
Can a behavioral outcome secondary to a medical educational intervention count as a clinical trial?
I think it would, yes. I think it would. Are you doing it on people? Are you prospectively assigning them to something? Are you designing it to see what the effect of your intervention is? You are, a medic, right? And am I evaluating a health, well, is it a health-related biomedical behavioral outcome? Might get sticky there, because, well, I just want to see if medical students are better at X, after my intervention. We'd have to see. We'd have to talk. I probably, but yeah. Okay, so what does this thing called the NIH look like? Now, one thing I learned very quickly after I got to the NIH in 2013 was that it's called the National Institutes, plural, of Health, not the National Institute of Health. And that is because the NIH consists of 27 institutes and centers, not 28, not 26, 27. And in the middle sits the Office of the Director, and then outside of it sits all these institutes. And the Office of Emergency Care Research is an office that sits within NINDS, so it's not one of the 27 institutes and centers. Why isn't there an Institute of Emergency Medicine or of Trauma Medicine? Well, in order for there to be another institute, you have to do one of two things. You have to get rid of one, because there can only be 27 by law, or you have to get Congress to appropriate and approve the creation of a brand new NIH institute. That would be the 28th institute or center or office. And you can imagine how easy that was going to be in the present partisan political state that we have, right? You can imagine how that conversation is going to go when we want to create another government body. So it needs literally an act of Congress to create institute. There was some time ago talk about joining together the National Institute on Alcoholism with the NIDA, the National Institute on Drug Abuse. Sort of kind of makes sense. And oh my God, was there a blow up about that. So, that's the reality of it, right? We might think that we need a special institute or primary care. The National Institute on Primary Care, goodness me, don't we need one of those? Doesn't exist at NIH. And where you're going to send your grant will depend on the research portfolio of that institute. So I work at the National Institute of Neurological Disorders and Stroke. Okay, so it looks at epilepsy and seizures and stroke and TBI, but it also looks at regeneration of peripheral nerves and spinal cord injury and so on and so on and so on. Now, where does meningitis fit in? Is that a National Institute for Neurological Disorders and Stroke problem because it's an infection of the brain, or is it a National Institute for Allergy and Infectious Disease problem because it's an infectious disease? And there are things called receipt and referral guidelines where this is all kind of mapped out. Sometimes there's a back and forth about who should be getting this grant, but generally speaking, these rules are laid out. And if you're not sure, that's the first place you need to start thinking about it, is which one of these institutes is going to support my question? And unfortunately, there are some things that slip through the gaps. So for example, I want to do a study looking at discharging patients from the ED better. Something I think we all feel we can improve on, rather than pressing on the Cerner discharge instructions. Here's 10 pages of lawyer-created discharge instructions. So maybe there's a better way of doing it. Maybe I can give somebody a video discharge. So I want to study that. What a terrific idea. Who's going to fund that? Which one of these 27 institutes and centers has as their portfolio emergency department patients, otherwise unspecified? Okay, well, it's yours, Brown, right? Because you're at the Office of Emergency Care Research. Yes, but when the Office of Emergency Care Research was created, there was no funds that went along with it. So I don't have any funding to give you. The best I can do is be a matchmaker and find someone to help fund you. So that would come to my office, right? Great idea, but it doesn't work. So you've got to get creative. Okay, I really would like to talk about, but what if I just look at how are we discharging patients from the ED who have asthma? Oh, what about okay, so asthma. So who does asthma? Oh, wait a minute. There's an institute called the National Heart, Lung, and Blood Institute. Lung asthma. Oh, so maybe my study should go to heart, lung, and blood because they're the people that look at asthma. So I'm going to do not all comers, but I'm going to focus on how can we discharge patients with asthma better from the ED, right? Now, do you see how the study would be better, I think, if you just focus on one disease group rather than trying to do it for everybody. Then you could say, okay, well, what about if I want to do it in children? I want to do children with asthma. Now there's another institute, right? It's called the Shriver National Institute for Child Health and Human Development. They look at child health. So that's maybe where so you see how, exactly how you figure out the actual clinical question that you're trying to answer. That will help guide you to the institute, because you can't just, well, you can actually just send a grant to NIH. You can just put it in the mail or press send, and off you go. And NIH will take it, and then if you haven't done it before, it will assign it based on its clinical question to one of these institutes, and it'll get reviewed, and you'll get a score back. That's a terrible way of doing it, by the way. You should, we can spend time talking about this, you should always talk to people at NIH before that. But each institute informs and advises the applicants, and it manages the portfolio, and it monitors the progress made on the grant. So, yes? No, you can't do it at the same time. No. Right. Right. So that's, yes, and this can sometimes happen, that it's not exactly clear who is going to. There's certainly overlap. There are sometimes overlap. So we get many grants at NANDS, the Neurological Institute, that are looking at children with certain neurological diseases. So is that a pediatrics thing? Should I go to the Pediatrics Institute? Is also one of the things that really think about is how rich are the institutes. These institutes are very. There's a big spread of money, right? So the wealthiest institute at NIH is cancer, yeah, cancer. So that gets, I don't know, $8 billion. The budget of NIH is around $40 billion a year, and about 80% of that money is sent out as grants. So you've got institutes that have billions. I think NINDS has around $4 or $5 billion. Depends how you count the money, because there is additional money. For example, Congress appropriated money for what's called the BRAIN Initiative to cure Alzheimer's disease, and that's extra money, and it's split between NINDS and the National Institute on Aging, because they are the lead institute for Alzheimer's. So anyway, these institutes vary a lot in how much money they have, in how readily they support clinical trials, and the personnel that they have, right? Because you're going to really want to talk to a program officer within each institute. So it's the National Institutes of Health, and each one of these institutes, by the way, has grants and uses grants in a certain way. One institute will say, oh, we never used the R15 award, right? So you're saying, I'm going to do an R15. I figured out what that is. I'm going to get some preliminary data. I'm going to send it to this. And then you go, oh, that's really weird, because the institute that I want to send it to, they say, we do not use the R15. It happens. So think about the NIH as these kind of self-governing islands, and each one does things its own way, and each one does things, has a portfolio, and some things are outside their portfolio, and they'll say, no, we can't, this is not something that there's in our mission statement, and since we have more than enough grants to support, we can't take this on. One of the first moves that people at NIH will do is try and get rid of an applicant, say, oh, it's not within my portfolio. And they'll say, sorry, all right? And, and it seems kind of brutal, but there are so many things that clearly fall within a mission of an institute that to start sort of negotiating things that are on the periphery is very challenging. And that can be hard for emergency medicine, but we can get around it. Okay, so now, you have an idea. Does tamsulosin help for kidney stones? It seems a good fit at NIH. You've decided you want to get some funding for it. You know why you need the money. You've looked on Nih Reporter. You've talked to your colleagues. Next thing I really want to encourage you to do is to get a copy of a successful application. Now, you can ask your colleagues for this. There are a couple on my website. They're pretty old by now. When I submitted my R01 application to NIH for a study of Tamsulosin, I had no idea what an NIH application looked like. I had never read one, I'd never seen one. So the first thing I needed to do was get hold of one, and what I did was actually I wrote to a colleague who I did not know well, but I said, he'd just gotten funding, and I said, could you share your grant with me? I'm doing it in a complete, his thing was on brain trauma, mine was on kidney stones. Could you share your grant with me? And he kindly enough did, and it was super helpful. So, doesn't have to be in your area. Don't get it original, get it right. So find a grant, and better yet, find a successful grant. Find a grant that was funded. It doesn't have to be in your area. Ask your colleagues, your SAEM, ask your mentors, ask your mentors who have friends. Get a copy of a grant. It will really, really help frame what it is that you're going to do. And again, look on Reporter for successful funding. Now, and then meet with your academic research office. This was something I learned the hard way. So every medical school has a research office, and you need to tell them that you're going to be applying to NIH. You need to do this kind of early for any number of reasons, not least of which is they need to get lots and lots and lots of people to sign off on your application. You can't go to your budget, you can't go to your office 2 days before and say, okay, here's the PDF. It has to be routed through the VP of research, and then who knows how far up the train it goes. It does. And then if the system is down, you're in big trouble. So you have to go and meet with your academic research office. They also have a lot of experience with this. They'll tell you, they'll help you. They should help you. And they'll help with uploading your application, and you can't technically move forward without them. You can't do this unless they sign off on it, because those are the way that the institutes work. It comes from, those are the way the medical schools work, right? So you must get them involved. So meet with your academic research office as you start to figure this out. And then, of course, the next thing that you need to do is to start writing. Okay? Now, assume a much earlier deadline than there is. Most grants at NIH can be submitted 3 times a year. In other words, there are 3 review dates. So it's every 4 months. So you've always got one coming up. Sometimes, though, there are specific. Sometimes there's a one only. Sometimes there's twice. So read it, but basically assume an earlier deadline than the one you have. There's a research strategy. That's the meat of your grant, right? What am I going to do? Why am I doing it? And how am I going to get my answer? That's the research strategy. There's a lot of fluff that goes around the outside, right? You've got to send your budgets, which can be pages long. You've got to send the bio sketches of all the people who are involved. That's many pages long. You've got to send the references. It just goes. You have a 1-page summary. You have right. So there's lots of other things, but it's this research strategy, this 12-page research strategy, that is really what it is. That's that the reviewers are going to look at when they do this. And as I said, there's all other stuff as well. And then you have your budget and your indirect. So you calculate the budget. You add in the indirects will be depending on which institution you're at, and that gives you your final project amount. It's really important here to be talking with someone at NIH. As I said, if you have someone that you know, or you are given a contact and that person is being helpful or is the right person, great. If not, I'm happy to help facilitate, introduce you to the right people. But you want to speak to the project officer. Say, hey, I'm thinking of doing this project. I think it fits with your institute. Does it sound like the right thing for you? And they'll be honest with you, and they'll say, oh, yeah, no, this is a good fit. I like this, or well, we had one like this before and it didn't go well. Whatever it is, the speaking with the project officer is really important. They'll also be able to tell you which mechanism to use, which kind of grant. There are dozens of different grants at NIH. For example, the R01 is the most common one, as I said. There's no limit on the funds you can ask for. You can ask for $50 million if you want. But if you are applying for more than $500,000 a year in direct funding, then you do need permission. So this is a sidebar. If you are doing a grant, if you're submitting a grant that in any year has more than $500,000 of indirect costs, you can't just put it in the mail and send it to NIH. you have to get permission from them. And the reason for that is that we want to make sure that we have the money down the pike to fund a study of this magnitude should it come, right? So you do need pre-permit, and that will depend on each institute. Institutes do things very differently, but that is a general rule for all institutes. You just have to figure out how I get what I need for my institute. So for instance, at Heart, Lung, and Blood, they have this thing called a large panel discussions where they discuss all these huge grants, and I think they only meet twice a year. And at NANDS, we do this every month, basically. So you can see that would change the trajectory of when you're going to apply. R03 has a $50,000 limit for 2 years. R21, $275,000. So there are different rules and regulations for each grant. You have to make sure you read them, and not only that you read them and understand them, but that you understand what the institute does with those grants. So you could have an institute that says, oh no, we don't fund R03s. It's not worth our time, or something like that. So you do have to know that. And the same for K awards. Now, the question, yeah? They're not total, no. They're direct. Okay, now, once your submission is written, it's really helpful to have somebody read and critique it. It takes time on that person's part, but this is really helpful. Things that you might think are really clearly written, somebody else might read it and say, I don't get this. And remember, the people who are on study section, who are basically your peers, remember, NIH doesn't review grants. I don't review the grants that come in. I listen to a study section, which is made up of about 12 or 15 peers, university people, who are reviewing the grant. You have to convince them. So you want somebody who can read it and critique it. One of the things that you should think about is which study section. There are about 180 study sections at NIH. Okay, everything you can think of. Most of the time it'll be very clear which study section your grant should go to. If you don't ask for a study section, they'll just assign you one. But it is useful to think about it, and that's where that Nih Reporter website is useful. Because let's say you're doing a grant and you want to look at something, type that keyword into the Nih Reporter, get ahead, and you'll see which study section it went to. You won't know who reviewed it within the study section, but you can actually see the names and the academic affiliations of every person on study section. That's publicly available knowledge. So you can get a sense of, is this a good fit? Now, those study sections are made up of core people plus ad hocs who are brought on to review something. So I was once when I was at GW, I was an ad hoc member of a study section of the National Cancer Institute because they were reviewing a grant looking at palliative care in the ED, and they had nobody from the ED. So they asked me to come on as an ad hoc reviewer, which is exactly what should happen when something is slightly out of the experience of the people. So think about what study section you want it to go on, and that you can do, as I say, by looking at NIH Reporter, finding a grant that was sort of in the same area as yours, or getting advice, or speaking to the project officer, and so on. So in your cover letter, you're going to suggest a study section, you're going to suggest an institute for funding, and any unusual expertise. So there may be that you're doing a study that requires a pediatric radiologist. Right? I need a pediatric radiologist to review my grant, and you can ask for that in your study, in your cover letter. You can't ask for the person by name. You can't introduce, your friend because she's a great pediatric radiologist. You can't, but you can say, because of the content of this grant, I need, and most of the time, the study sections will, or the review people will get the right person on the grant. That's something that I do quite a lot of, actually, is help to bring people to review things that are needed. Now, sometimes they won't, and that can be disappointing, but by and large, the study sections do their best to have the right expertise. And one of the things you can do, by the way, is consider becoming an early career reviewer. You can Google that on NIH Early Career Reviewer, and you basically sit in on a study section as a sort of a junior reviewer. You'll get assigned a review. I know there's going to be later today, there's going to be a sort of a mock review, and that's very, very useful. There's actually, on the NIH website, a video of a review section at work. I think it's on a basic science project, but it is really worth looking to see. What happens at review is that your grant, well, one of two things will happen. It'll either be non-discussed or it'll get discussed. Non-discussed means that this is not going to get funded, and it's not worth our time to talk about it with everybody, because we meet, usually over a 1 or 2 day period. Used to be in person, now it's all done by Zoom, and I think everyone's happier with that. But it used to be that reviewers would fly in from all over the country and meet, usually often in Washington, but not always, and there wouldn't be time. So sort of half the grants, the worst half, are not discussed. And then the best half are discussed, and you can spend 45 minutes hammering out a grant in a very, very in-depth discussion. Regardless of whether your grant is discussed or not discussed, you always get a summary statement of what it was that the reviewers thought, anonymous. Reviewer 1 said, reviewer 2 said. But we'll come back and talk about that in a minute. So anyway, become an early career reviewer at NIH. It's a very interesting thing, and if academic research is important to you and you think that's really what you're going to make a career in, it's a good move. And then finally, through your research office, you're going to submit your grant. It's all done now online, obviously. Back in the day, I had to make 11 copies of, I have a picture somewhere of the material that I was sending by UPS the next day, and 11 copies of the grant, and the grant binder was that thick. I had one of those trolleys, and I was pushing. I mean, it's crazy. Now it's all done electronically. So, list people who should not review your grant, list people who, which study section, first choice, second choice, third choice. Anyway, you'll see all this online, and this is where your mentors, your colleagues, and of course your research office will be a tremendous help in making sure that you get to the right place. And now what happens after you've done all this? Well, basically you wait, right? We said that if something happens, in order to get the grant, it's going to take around 18 months if you have a good wind and, all the stars are aligned. You've got 3 to 6 months pre-application, writing the grant, doing all that background work, then you submit it, gets to NIH and it's referred, meaning it goes sent to a study section. And then about 4 months after that, the reviewers review it. Obviously, they've had to spend time reading all the material. So you're sending them a form this big, a grant this big, they're going to have to read it. And after it's reviewed, a couple of months later, you get that summary statement. And what happens then is the grants that score very well, and by scoring well in the NIH universe, it means they get a low score, which is kind of backwards, but that's what it means. So the grants that get a very low score, meaning they score very well, are discussed internally by the institutes, and they go forward to what's called the advisory council. Each of those institutes has an advisory council. Think of them as the board of directors. Again, it's predominantly made up of people from universities, and they are the board of directors, and they have to approve all the grants, which is why even once you get a great score, then nothing can happen until within the institute we say, yes, we're going to bring this forward to funding, and then it goes to council, and then finally council give its approval. Finally, the notice of grant award is sent out. So, that's at least 9 months from the time you submitted and about 1.5 years from the time you first had the idea. And of course, if you didn't get funded that first time, but you're going to revise and submit, then you go back to here. But you go back to here knowing what it was that they didn't like about your grant the first time and improving it and responding to everything that they wrote about in the grant that they didn't like. So the way that grants are scored at NIH review, as I said, it goes backwards. High impact is 1 to 3, fair is 4 to 6, and low score is 7 to 9. And they're in these areas: significance, approach, investigators, innovation, environment. Most of the time, people really focus on the significance and the approach. And to us, obviously, the investigators. The environment and innovation, I mean, innovation, you're doing a clinical trial, hundreds and hundreds of clinical trials done every year in the country, thousands of, how innovative is it? But if you really want to do something that's different, that's the place, your environment. How good is the school and the medical school at where you are? But I think, the significance and the approach are really the key things. What is it that you want to do? Why is it important? How is it going to impact patient care? And how good is your approach? Maybe it's a really important question, terrific question, but we think you went around, the reviewers, think you went around it the wrong way. So you could have a very significant question and the approach is all wrong. Or you could have a terrific study, but who cares about, it's not studying an important area. So based on those things, as I said, it's either discussed and not discussed, and you get a raw score and a percentile, and then everyone gets a summary statement. Now, this time, when I would give this talk before I would give out the summary statement, it was mine. I didn't do it this year for time, but I think it's on my website, Office of Emergency Care Research, what a summary statement looks like. And I said, it is each of the reviewers, so there are basically usually 3 reviewers who are assigned to a grant, and then everybody else, the rest of the 10 or 15 people sort of chip in and listen. And the primary reviewers give you this sort of in-depth summary statement. So I wrote my grant to NIH, R01. Like I said, I got a copy of the grant. I submitted it. And remember I told you half of them are, discussed and half of them are not discussed. So my terrific grant was not discussed. What? This is a brilliant idea. How can you not even discuss? It got the kiss of death. Why did it get the kiss of death? Because I was going to do steroids. At the time, I was going to do tamsulosin and steroids. And steroids are very, very dangerous, said one of the reviewers. I'm sure all of you know this because when you give out your prednisone taper or your 60 milligrams of prednisone for 5 days, you realize that you have to get a pregnancy test on all the women before you do that. I'm sure you all do that, right? Because I certainly know that I actually didn't do that at all when I was practicing. We just, hey, okay, better, right? You look good to go, obs of ED obs. Here's your steroids, bye-bye. Well, that is a very dangerous thing, said one NIH reviewer. So he or she had human subjects concerns. If you have a human subjects concern, that's the kiss of death. So I think we can all agree that was probably a little bit of an unfair criticism, and they bring it to your attention because sometimes you can get things that the reviewer was out of their knowledge area. They didn't understand, either because you didn't explain it to them or that they just didn't understand that it doesn't work that way, or it's not how we do it. So some things are fair in life, some things are not fair in life. As I told you, this is a marathon. You have to be committed to it. After my study was not even discussed the first time, I revised, I resubmitted, and the next time through, it got funded, and as I said, brought $4 million and another $2 million in indirects. So, it's disheartening, but you have to stay at it. So a study can be not discussed for any number of reasons, but it's disheartening but you will get a summary statement, and you can take it from there. So now, what happens once you get a fundable score? This I want to spend a minute or two on. This is really important. There are 2 ways of thinking about the fundable score. Once you get a number, you can say, oh, I'm going to get funded, right? Or I'm not going to get funded. I got a score that puts me in the 18th percentile. My score was in the top 18% of all the grants. And I'm at an institute that only funds up to the 15th percentile. Because I told you about 15% of R01s get funded. So I'm not going to get funded, right? I just missed it. So not necessarily. So different things that can happen. Usually, all the grants that get a specific score, remember lower is better, so that get below a specific score will get funded. So anything that's up to the 15th percent, I've seen this. I've seen grants that are in the 1 percentile. They had 99% of NIH grants did not score as well as they're in the top 1%. They're going to get funded, right? But anything usually within a percentile will get funded. And some institutes say this. And they'll say the most important factor is your score, and we're going to basically fund all the studies up to the score, and then we're going to stop. We've run out of money. That's it. We're done. But, and this is an important thing to note, in this example, NIAID, the Allergy and Infectious Disease, has something called Selective Pay, which a small number of grants who just fell outside of that funding range can get funded, right? And the person who's going to go to bat for you in those internal discussions is the program officer, the PO. So remember I told you a few minutes ago that you can submit a grant to NIH and not talk to anybody? You can. It's not a good idea, because if this happens, you need a project officer who you've got a relationship with to say, I know you didn't fall quite out, you got an 18th percentile and we only fund up to 15, but I really believe in it, and I'm going to bring it to council, I'm going to bring it to the internal discussion, I'm going to bring it to council, and I'm going to explain to them why I really think we should fund this. And it happens. Either money they found some money in the seat cushions, or there's all kinds of reasons that money can be found, and so it's really, really important. In choosing applications, we look at relevance to our mission, scientific merit, and whether an investigator is new. And that's really important as well. So here is, for instance, the National Institute of General Medical Sciences, the Basic Research Institute. They have about $5 billion a year. It nearly all goes into basic research, not clinical research, but it might be something that you're interested in. So they say, we meet and discuss after we get the reviews. We meet and discuss. And it is driven by the score. However, they say, we have other factors like reviewer differences of opinion, or the advice of counsel, or whether the investigator is new or not, and so on and so on and so on. And so they say we look at a range of applications on either side of the pay line, meaning that NIGMS might say, yeah, you did score in the 12th percentile, we're not going to fund you. We're not going to fund you. It's on our website. The score is only one thing. We don't believe in it, the director doesn't want to do it, whatever it is. And so that can happen. It's not common. It's far more common to find, what we call stretches or reaches. But it can happen, especially in institutes that have this ingredients way that they do this is that the score is only one part of the decision process. Now, I actually think that this is the right way to do it. That it shouldn't just be solely driven by the score. There should be other factors that come in, and that this is where, if an institute is run very well, what the program officer's recommendation of the level of funding, it should be done like that, because it's not a hard and fast, everything up to this score should be funded and nothing afterwards. But most institutes are very much pay line driven, including actually NINDS. Here's an example of funding at NINDS. So everything up to the 15th percentile is funded. Everything after this is not funded. Then you have this kind of gray area in the middle, let's say from the 15th to the 25th percentile, which we can discuss. You can make a case for. If we have money, we might fund. So that's why, again, your project officer is the only one who's going to be able to bring this forward. So you have to have a good relationship with that project officer, and hopefully they'll be able to help you if you fall into this area. Here you can see some of the pay lines. This is the Heart, Lung, and Blood Institute. So they fund up to 15th, but if you're an early stage investigator, you'll get, you can score up to 25. Let's talk about early stage investigators for a little bit. I told you about the role of the program officer. We don't talk about that. Okay. Early stage investigators. This is really important, and I suspect this applies to nearly everybody in the room. An early stage investigator is somebody who was within 10 years of their terminal degree. So, for example, you're 10 years after medical school, you're 10 years after your MPH that you did after medical school, you're 10 years after your PhD. That's generally what it, or residency. And you haven't yet been funded at NIH. There are some grants you can already be funded on at NIH and still be an early stage investigator. And these people, these early stage investigators, get an amazing bump. They get a 10-point bump. So if we go back to this, if you scored here, you scored a 24, but you're an early stage investigator, we give you 10 points. And all of a sudden, magically, you become within the pay line. That's how it works. That's literally how the early stage investigator thing works. You get a bump. And it's important because what we were trying to do is move this curve in which the average age was going higher and higher and higher. The average age in 2010 of a grant was somewhere in the 40, 45 years old. People said this isn't right. We need to get early stage investigators. So really, really important. So if somebody, for example, says, would you be a co-investigator on an R01 and you're an early stage investigator, you should probably decline that. Because if you're a co-investigator on someone else's R01, you would then nix the opportunity to be an early stage investigator. So this ESI status is really important. Now you can go online and you can see exactly when does the clock start, when does it stop, what do you, for example, here you are, as I said, you're probably going to lose early status investigator if you're a PD on a multi-project award. So you really want to save your ESI. It's terrific. 10-point jump is just amazing. Yes? I don't know. Yeah. You should be okay, yeah.
Double check with the program officer. It's a little bit wonky, but
yeah.
For the most part, a co-investigator does not change your ESI.
It's huge. No, this is.
It should be across all.
Yes, this is across all institutes. Yeah, this is basically the compute. You put your credentials and who you are into your. Everybody who applies to NIH has to have sort of an NIH ID, as it were. You put your credentials in, the computer will spit out whether or not you count. It's exactly what you said. Here, I'm a co-investigator on the grant. You won't lose your ESI status. What if I'm the PI on a sub-award? You won't lose your status. Anyway, so it's really important, and really I want to encourage everybody. That's a great, what's the right term? ACE in the whole, I don't know what it is, but it can help you tremendously.
Is your terminal degree residency or fellowship?
Probably fellowship. Probably, yeah.
When I last checked, they defined it as the end of residency, not actual.
Well.
But talk with them. If you go through the thing online and you see that it doesn't have you listed as an ESI, talk to the POs of NIH because they can correct that.
Correct, exactly. Thank you for pointing that out. Yeah, so things can be corrected. The computer can get it wrong. You didn't enter the information correctly, or there was a special case in your part. So. Check your ARA Commons profile. That's your NIH ID, and you will and you'll get that. All right. The role of council. I said council is the sort of board of directors. They meet 3 times a year. They provide advice to the director, and they basically concur. Generally, they concur with what we recommend as project officers. We're going to recommend funding the following, 200 grants this cycle. They're not going to read 200 grants. Off they go. However, at NINDS, and I'm not sure this is true elsewhere, but at NINDS, every grant that touches a patient is discussed at council. So you could have a grant that scored well. The project officer wants to fund. We meet and we decide we're going to fund it. We bring it to council and say we want to fund this grant. And at council it's discussed because it's a clinical trial. And at council there could be concerns. There generally aren't because they respect what's happened at study section. But I've been seen grants that have had additional safeguards put in place at the level of council because for ethical reasons, whatever it is. So generally, council literally just sort of rubber stamps, approves whatever it was that study section said and that we at NIA within the institute want to do, but it's certainly not, that's not their role, and they will look at certain grants, especially the grants that touch a human being. So clinical trials in most institutes do get this additional level of scrutiny. As I said, if by any chance you're not funded on the first attempt, you revise and resubmit, you revise and resubmit. That's what I did, and I got it through the second attempt. You're allowed 2 attempts now, and then you have to sort of make it into a new grant, so you can do that. But when you resubmit, you have to make sure that you're addressing every single comment and criticism that was in the original study section report. I've listened in recently to a study section that had a revised submission, and one of the reviewers she said, I just don't understand it. We told them what the problems were, and they just ignored us. Now, you don't have to do everything they say. You could say, in the prior review, this problem was pointed out. We don't think it's a problem for the following reasons. Or we're not going to change it because it would. You can do that, but you have to address it. You can't just ignore it. And I've seen grants where we'll just send it back in. You have to go through every single comment and either fix it or explain why you're not fixing it. You can't ignore it, and you shouldn't ignore it. You're getting great advice from people generally, so you really don't want to ignore it. Now, K Awards, many of you know about these K Awards. They are mentored awards. They're aimed at people just graduating from residency or junior faculty, and they're different to the R Awards, right? The R Award is an independent award. The K Award is mentored. So on the K Awards, the goal is to bring the candidate to a place that she can then go and become an independent investigator. And on the K Awards, not only is the area that you're going to study important, but who your mentor is tremendously important, as important as what it is that you're going to do. And we'll probably talk about K Awards later in the day, but the most important K Award, I think, for most people in the room is the K23, which is the Clinical Mentored Award. For instance, there are basic science mentored awards where you don't touch a patient, but you still have a mentor. These are the clinical awards or patient-oriented research. You get at least $100,000 plus fringe, plus research support. And each institute has specific requirements. So you could have a K23 from the Neurological Institute or a K23 from the Mental Health Institute, whatever it is. And they're slightly different, so you have to tailor your application depending on where you want to do it. So yes, we really are here to help. I'm very easy to find. I'm pretty good at getting back to people quickly. So if you have any questions about where to go at NIH, questions that come up as a result of what you've heard this morning, things that are not clear, I don't think I'd phone me because I haven't been in my office for 2 years. And we went back, actually NIH as an institute went back about 2 weeks ago, but right before COVID struck, the building that we were in, there was a whole question, the lease was up, and so after back and forth about whether we're going to stay in the building or not, they said, well, we're going to renovate the entire building, and you can come back when it's done. And the renovation is currently underway, so we have no building to go back to. So I'm actually not going to be in my office till September, when the renovations will be complete. It's going to look fantastic. I went recently to one of the floors that is renovated. I mean, it looks like, talk about swanky and good use of your taxpayer dollars. Thank you very much. It's lovely. It looks terrific. It looks like kind of a Google office might look in your mind, except without the balls of the pit ball, the balls that you jump in, and the ping pong tables and all that. We don't have that, but it is going to look very nice. So eventually, I'll be back in the office. So for now, don't call me, but email me, and you're going to have a terrific rest of the day, where we're going to discuss your grants in detail, and you have mentors. A lot of people in the emergency medicine community who have great experience with applying. There are 2 emergency physicians, as far as I'm aware, at NIH. I was the only one. Recently, the National Institute for Child Health hired Dr. Cinnamon Dixon she is now the 2nd emergency physician project officer at NIH, and she's in the child health, so you have somebody there. And there's a lot of goodwill towards emergency physicians knowing what great and important work you do. Thank you for your time. I look forward to talking with you offline.